so much. Thank you for having me. It's been a great day so far. So this paper, as it's titled, is on looking at incentives for childhood immunization based on an experiment that I ran in Sierra Leone. And at this point is concerned about what can happen as a result of incentive exposure, which is intrinsic motivation might be crowded out. So this is joint work together with Juliet Finetti and Zachary Kulczewski, who's a PhD student at UChicago. So the motivation of this paper is that I think at this point we have ample evidence that convinces us that if incentives can be effective at increasing health behaviors. I added a few citations here that are by no means comprehensive, focusing mostly on immunization, as well as I think there's a lot of literature that has been looking in higher income countries at pro-social behavior and health, particularly around blood donations, where incentives can really increase take-up or participation. However, if you enter a room with policymakers, as I had to do during my PhD and still do, and start talking about incentives, whether that's financial or non-financial incentives, one of the most common concerns that's expressed is that incentives might actually lead individuals to less engage in a particular behavior once you remove the incentives. So they're very worried, not just from a financial sustainability side, that's I think was the first order argument too, but what it actually does to behavior. So when now stepping back and being an economist, thinking about what we have sort of studied and learned, we do have sort of this concept of crowding out of intrinsic motivation has been strongly documented initially in the lab setting. So individuals playing games around, whether to solve a puzzle, doing some kind of enjoyable task, and in one round, they would be exposed to an incentive and sort of their subsequent behavior when the incentive is removed. Interestingly, though, and I'm a development economist, so I'm thinking a lot about, policy and incentive programs in field settings, we have very limited evidence from the field that crowd out is an actual topic. So if you were to look at the handbook chapter by Michael Kramer, Gautam Rao, and Frank Schilbach in behavioral development economics, they would kind of say, this is sort of a done deal. We arrived at a point where really we don't have evidence for this to be a big concern. I'm mentioning two papers here, one by Nisi and Mustatini, which you might be aware of, the Israel study in kindergartens, where there is some evidence found how parents might respond badly once they're given an option to pay for picking up their kids' leave. But really that's limited and certainly not something from low-income countries. So why might that be when thinking about the literature that we do have in these settings? So most of the time, actually, what we find is persistent positive effects of incentives. And studied through, people find habit formation as a result of incentives, or that people are actually learning by doing once they're encouraged to engage in the behavior through incentives, or a recent paper as well looking in Brazil, that this can lead to durable investments in response to being exposed to certain restrictions when it comes to energy consumption. Now, all of these are kind of behaviors where we can think of there is some scope, as I said, for learning or habit formation. But we have actually much less literature that is looking at behavior, so we have a really high level of take-up, and we may not have scope for these kind of behavioral mechanisms to be at play. So the question we're asking in this paper is, does providing incentive to parents to vaccinate their child change their vaccine behavior for future children? And then secondly, do incentives change parents' intrinsic motivation, and if so, under what conditions? And that is mostly because we might expect to see different effects on future children's immunization behavior once you remove an incentive. But there are many explanations, and I'm going to go through them, that may not have anything to do as such with crowding out of intrinsic motivation. So it's actually quite challenging to say where we truly led to some crowd out of intrinsic motivation. So the room is, I think, very diverse in terms of backgrounds. To kind of set the stage a little bit more, please let me know if I'm blocking views or so. I have a talent of moving around in front of my slides. So what we're sort of basing this conceptually off this paper is a distinction between intrinsic and extrinsic motivation in economics. Certainly not originating from economics. There might be sociologists sitting here or psychologists who are familiar with that. But Menabo and Tirole have moved this kind of concept into the economic domain. And they're basically saying that individuals have these two competing motivations. And extrinsic motivations might be coming, through contingent rewards, meaning I say do X and I give you a certain type of reward. And in intrinsic, we're thinking about individuals' desire to take an action out of pure joy, their own sort of willingness. And what we're concerned with here is really kind of thinking about how do these two types of motivations interact. Meaning, once I introduce an extrinsic reward, what might be the effects on your intrinsic motivation? And it could potentially be that there is a crowding in, so meaning like your intrinsic motivation to do a certain task might actually be higher once you be exposed to an incentive. but it could also be that it reduces it. And so what we're interested here as well is, kind of understanding what might be the psychological effects of incentives, not just the economic impacts that you observe in the short run when you introduce incentives. And what I should be very clear and what I need you to sort of think about as I continue talking about this topic is most of the time when we're thinking of incentives, we're thinking about the people who are marginal, meaning people who are currently not taking an action, but they could be induced to change their behavior, meaning they could be induced to take up a vaccine or deworming treatment or whatnot. Here, in this context, we're thinking about is people who sort of the always takers, who would have taken the action even in the absence of an incentive. And then once you introduce an incentive, what happens to their motivation or their willingness to take the action once the incentive is removed? So we're not thinking of those, we normally want to induce to take it. We're thinking about people who might already take the action of doing something environmentally friendly or taking up a certain health behavior.
Can I ask a question?
Oh, absolutely.
So with the crowding out, is the idea here that you sort of won't want to do it because you'll want to wait till sort of when the reward would happen again, or is it much broader than that?
It's much broader than that, and I'm going to give you a few examples in a moment, and if it's still not clear, then please ask the question again. So here, actually, I'm just at that slide. Sort of how can we think about and I'm just naming a few, and again, I'm sort of basing this off the paper by Roland and Jean of 2003, where they explicitly studying this interaction. And I think there's sort of three relevant, there are a bunch of other ones that they're bringing up, but in terms of the setting here, there's three relevant explanations that particularly in a setting where you have a government and maybe a citizen, you have a provider of education and health, and you have like a household, in that kind of setting that might be really relevant. So one, first of all, is intrinsic motivation might be sort of diminished in result to being exposed to incentives, because we're in a setting where individuals don't have as much information, let's say, as the government. And what they're doing is by introducing an incentive, they think, oh, maybe actually that means the action is not as valuable because I need to be swayed to take the action, or the action is more costly. So they could be sort of updating, learning sort of like about how valuable the action is. That sort of affects their motivation. A second aspect is, which might happen, they kind of thinking that actions that we're even taking repeatedly, we may not always have perfect memory, remembering our own motivations for taking an action, particularly when something is hard or costly. We might ask ourselves, why again am I taking the action? And so self-perception and memory might play a role in the sense that when you recall the last time you took an action, and all of a sudden you remember you were given an incentive there, that what you might misattribute sort of is that you think more visually or sort of saliently of the reward or incentive that you were given than kind of thinking of your own intrinsic motivation. It's sort of like inferring, it's an interference with the signaling problem in the sense you all of a sudden have two explanations that you could draw from why you took the action the last time. Not just your own motivation, but maybe it was just the external reward. And then the third thing, I think quite intuitively, it might affect dynamically your future expectations. Once individuals begin, to expect a reward performing an action, they, when they're consistently exposed to it, they kind of expect it and they rely more on this extrinsic motivation, and this reduces their intrinsic motivation. So these are sort of just kind of anchored, you're thinking around how might this come about. I'm giving you three examples, and I'm going to revisit them in the latter part of the talk to talk about potential mechanisms in this setting. So what are we doing in this paper? So what we're doing, we're having a contingent reward, an incentive that individuals are exposed to. Specifically, we're looking at a field experiment where an incentive was implemented by government, by health workers. And the incentive was implemented over like 2 years, and we measure behavior 2 to 3 years after the incentive was removed. So this is quite different, I just want to say, from a lab setting where you play round one of a game and you look in the next round, how's that going to affect behavior? We're looking here really 2 to 3 years out. Does it still have an effect? Secondly, I believe that this is a setting where crowd out might actually be quite relevant. This is not an argument. I just want to say that, did someone else get it right or wrong, or we get it better right? No, I think we're just providing one context that might be quite different from other contexts that people have studied persistence. And this is one where we're looking actually at a well-established behavior with fairly high take-up levels. Normally, this is characterized by a last mile problem, where you want sort of like universal take-up of an action. And so we think there is limited scope, and I'll show you some data for actual learning by doing or habit formation, which is quite different from the other settings where I showed you persistence literature. Then what we're doing then in the later part of the paper, we're really trying to get a sense of like, what is happening as we're observing negative behavioral effects, sort of distinguishing motivation crowd out from other effects. You could imagine as we're in a real world, implementing incentives is not just affecting recipients, but could also affect the broader community or even those people who are handing out the incentives. It could shift, for example, effort of health workers who are giving out the incentives, and that could explain negative effects. So then I think the nice thing about this paper, which is not commonly done, is we have actually a comparison between people who were directly exposed to the incentive and individuals who did not experience the incentive, but they know about the incentives. And I'm going to explain that in a moment, but that's going to be a key part of the research design. Mostly persistence literature is focusing only on individuals who have directly experienced the incentive and what happens to them. They're not sort of looking at overlapping generations or people who were sort of adjacently exposed to it. And then the last part of the paper is that based on the original experiment, we have variation in the type of incentive. As I said, a lot of work is normally done on financial and material incentives. Here, what we have is we had 2 incentives that were rather perceived as a normal small gift. And then we also had 1 incentive that was very much tied to your intrinsic motivation to demonstrate that you were a caring person. So the preview of the results, what we find in this paper that incentives reduce parental effort to vaccinate their children on time, but they do not change vaccination attitudes. Meaning we're going to show you that people are less likely to timely take their kids to vaccines, but if you give them enough time, let's say 1.5 years, they will eventually come, which is to be expected. Like we didn't as such create anti-vaxxers, one could say, but we made them exert less effort. The negative effects are concentrated among parents who directly experience the reward. And that, we believe, sheds evidence on that this is coming through a channel of reducing intrinsic motivation. We find variation, however, by incentive types. So incentives that were not tied to intrinsic motivation, but were rather perceived as a regular reward. We find large effects on reducing the timely number of total vaccination by 5 to 11%, whereas we find very small and insignificant decline of 3% when it's linked to an incentive where you can demonstrate you're a caring parent. Basically, an incentive that is directly linked to your intrinsic motivation. And I think this is really the suggestive part of this paper. I want to be quite clear here. This was not an experiment that was set up to test crowding out. I would have a more refined design and data. This is really, studying something in the wild that was unanticipated. So we have suggestive evidence underlined that these individuals attribute their past decision to timely vaccines more to external rewards, and they have changed their expectation. These are the most likely channels that we arrive at as we're sort of going through the list and bringing all of our survey and outcome data together. So let me say something to the contribution, because again, there's like different people from different fields here. So where do we think this paper fits or matters? So on the one hand, we think that this paper is important because it generates evidence of long-term crowding out of intrinsic motivation. It's the first study to show that crowd out can persist even 2 to 3 years after exposure. And it is also one of the very few that is actually studying this in a low-income country setting. Then secondly, we're looking at something which is crowding out after the incentive is removed. Most people are looking at crowding out of intrinsic motivation during the implementation. There might be reasons why you might not find it during the implementation, because actually there is a positive value for the incentive, but motivation still changes. There's very little literature on that. Lasatera, of course, in his work on blood donations, has some work on that, but there are very few papers on this. Then secondly, we're finding evidence, supporting actually sort of thinking about when crowd out might occur, because that's really, I think, the question in the literature now. We have this sort of different evidence of like, well, we don't find any crowding out for incentives, where we're encouraging VetNet take up, but you just show me a paper where there's something on vaccines for kids and all of a sudden you have some crowd out. So I think the really important margin here is to think about squaring this with the theoretical literature, conceptual frameworks. When should we expect, when is crowding out of intrinsic motivation more likely to happen? And can contrast this, with other contexts where, as I said, where there's learning or habit formation. And then thirdly, I think this generates some important insights for designing incentive-based policies, where we normally mostly focus on incentives that, affect the marginal people, like new adapters. We should think very carefully, about those who are already designing this behavior, performing this behavior. Also, that potentially this is another strength of incentives that are directly emphasizing the intrinsic motivation of a parent, that they might actually have less of these adverse effects potentially. And thirdly, and this was not done in this paper, because I was a PhD student and, well, it was an RCT at the time, but I think there are limitations certainly in the setup where one could be much better thinking about really careful communication about the removal and phase out of incentives. Actually, I want to correct myself because I think I misspoke here in a sense. If I think about all the incentive programs that we look at, even in high income country settings, mostly this is something that's just not done. Something just ends. An incentive just disappears. We no longer have funding for this program, whatever, and this is actually also the context we're in. There's a high level of uncertainty over whether something happens or not, and things just discontinue. So the overview of the paper, what I'm going to discuss is give you a little bit more feedback on the context of this of this research, then talk about the research design, the results, then hoping to get to really think about also how these effects are different for different subgroups. As we're thinking about from a policymaker point of view, who do we have most worried about when thinking about crowding out, talking to the mechanism, and probably won't go there, but there's also some stuff on policy relevance, and I may have to ask you to go to the paper, which is only 20 pages at this point. If you know all the figures and graphs, it's only 20 pages of writing. I'm very proud of that because it usually doesn't happen in the Econ papers. So going into the context, so what we're talking about here is, Sierra Leone is in West Africa. It's one of the poorest 8 countries in the world. However, one thing that works quite remarkably, because a lot of money has flown into this, is childhood vaccines. So the way this is working, and parents are also aware of this, is that a child under the age of 1 needs to receive 5 vaccinations. Most parents complete the first vaccine on time. I'm talking here about 99% take-up, but they delay or miss later vaccines in the schedule. Importantly as well, and this is sort of a nice thing that allows us to study the way we do, is this is a repeated behavior. So fertility rates are quite different from the ones that we just discussed in the US. Women on average have 5 children. So they will have multiple times to take the action of vaccination. So the original research was in 2016 and 18 implemented, where we introduced an incentive for timely immunization in the form of color-coded bracelets. To be clear, these incentives, I'm so sorry. These incentives at the time, I'm just going to show it to you so you can actually visually think about what this was. These are little bracelets. They have knobs because kids, for anyone who has kids' wrists are growing as they're aging between 0 and 1. So this had to be size adjustable. And so there were differently colored bracelets that would say how many visits your child has done. And it was the case that entire clinics and all of their communities around them were assigned to either receive these bracelets and hand them out or not. And the primary outcome back then was timely and complete vaccination under the age of 1 year for kids. So I need to walk you a little bit through, bear with me, on the original design, because it sort of makes you understand that we had a variation in what type of incentives were implemented. So the first type of incentive was a bracelet that worked as a signal of being a caring parent, which means you had like a first yellow bracelet when you came for your kid for the first time. And then if you made it all the way to the 5th vaccination, you were given a green bracelet.
Can you just clarify what you mean by being a caring parent? I'm
yeah, absolutely. So this is
how they're thinking about vaccination.
Yeah, exactly. So this is a total context question. It could signal many things. So a core part of the original paper, and I won't have time to go through this. I think it's a challenge with a follow-up paper. You need people to have knowledge of what it was, but I don't have enough time. Is that in this context, social norms are such that when a parent is not vaccinating their child and you ask what they think about them, what the inference would be, it is not that they're poor or they're just not well educated. The most common answer, and we're talking about 90% of people would say that, is that they're negligent. That they're a negligent parent. So
I see. So that's the perception in the country at the time.
that is a perception in this context where we're working, yes.
Got it.
So this is there are other contexts, of course, where other norms are established, but this is sort of the norm on which this intervention was built on. And so this type of incentive where, childhood immunization is not commonly visible. You might go with your friend to the clinic and they might have a sense whether your kid is vaccinated or not, but it's not the case that the community in general knows whether your kid is timely vaccinated or how far. What this intervention did originally as an incentive, it gave you a small reward at the beginning, was saying, hey, when you come with your kid, you're going to get a little bracelet, and people positively value that just as a reward. But importantly here, there was a difference that whether you could show that you completed the vaccination. So then there were 2 other types of bracelets. And again, to be clear, this was different clinics were giving out different bracelets. So it wasn't like all of this was going on at the same time. There were different clinics with different types of bracelets. There were two other ones which did not work out as signaling bracelets in a sense, which is they both had the feature that you were also getting a bracelet at the first visit. But then here you got a green bracelet on not the last visit, the fourth one, which is a visit, a vaccine that parents just don't value as much. There is a bit of a caveat here. What do you think is an important vaccine? Measles is really important. People think it's really infectious. I don't really care if you got the third pentavalent for diphtheria or whatever. That didn't work out. And then we had one where basically there was no other bracelet in terms of color at the end. So we're thinking about these sort of like labeling them what they actually turned out in the initial paper as a signaling reward, here an initiation reward, meaning they were given this bracelet if they came for the vaccination at the beginning, and a double reward because they were given a first bracelet. And if they came later, they might have gotten some praise or scolding or whatnot through a green bracelet, something that happened there at that point. And then there was a control group where there were no bracelets handed out. So just to let you know, for anyone who has concerns about this, but this was really high quality implemented. There was no differences in arms or whatnot. And this had large effects for the signaling bracelet, which increased vaccination by 13%. The other two had no distinguishable effect. And survey data after 2 years of exposures to these bracelets in your community, lots of people having them, showed that there was no learning among parents about the private or social benefits of vaccines. To be clear as well, they commonly think that vaccines are like a good thing to do. And few people have like concerns about this being harmful, and it's mostly because your child's gonna cry and there's side effects as such. So this experiment ended in August 2018, which is sort of the time when I was back at Berkeley writing a job market paper, and no more bracelets were given to clinics. To be clear as well, we communicated, we went to all the clinics and told the nurses, you no longer implement this. They knew it was a pilot, this ended. However, they still had some bracelets with them. Between December 20 and July 2021, we then went out and revisited all the study communities and collected vaccination data on over 11,000 children to see what happened to children who were subsequently born. And what we found out as part of that, which was very surprising, that clinic staff, in spite of constantly complaining during the time of the intervention and a lot of effort going into incentivizing them to do the work, continued handing out bracelets after the experiment ended. So the analysis that I'm going to use for this paper is not going to be the full sample, but it's going to be a subsample once the implementation actually was very low. So to just show you, what happened is this is the implementation period 2016 to 2018. There was a very high handout rate of like over 90%. Towards the end, it dropped a bit. We did less monitoring. We were less present. We told them period ended, no more bracelet program. Nurses continued handing it out at similar rates across all these clinics, these different arms. And then we're sort of entering a phase here where the probability of you getting a bracelet is below 10% on average. And I'm going to use the data from this period here. Again, messy world and not expected. Any questions?
This is going to seem like a little question, but I can't tell the difference between the fourth visit bracelet and the fifth. So I'm just wondering about what the signal is if people only see a green bracelet.
Yeah, so they would know. There would have been, people would have known. It says it on the bracelet, but more importantly, nurses were explaining it, and there was a lot of community sort of information around it. That if you were in a community, in a clinic area where it's on the fourth visit, it meant that you had completed the fourth vaccine visit. Whereas when you were in an area, which is a totally different set of clinics and communities, when you see the green bracelet, you would have known, and we have data on that, that caregivers knew that. It meant that you had completed the fifth visit.
So the communities are that distinct.
Yes, completely distinct. Okay. These are like 10% of government clinics over, 6 districts, giant geographic space. They're not overlapping.
I have a question.
Yes.
So I know you said that not vaccinating was like not interpreted as a signal of like sort of being low income, but is there a monetary cost to the vaccine?
You have to travel to the clinic. Over 90% of caregivers are walking. So you could say there's an opportunity cost of time. Again, most, women here are involved in farming and so on, and there's some cost, but there's no fee for the clinic. So we have some data on paying for something. It's more like, did you give something to the nurse? About 18% of people report giving something to the nurse at some point during the experiment, but there is no fee as such, and you don't pay for the vaccines. The vaccines are free. And so there is no a correlation as such that we're picking up in terms of income ingredient. But people are also generally just very poor. So when thinking about, so how we're going about here, thinking about identifying crowding out, or just thinking about learning about what happens after the incentive removal. So what we're going to do is we're going to measure the effect of the incentives on timely vaccination completion on future children after the incentive is removed. So these would be all the children that are born subsequently in this time period. And we're going to exploit, first of all, the original random assignment, right? So we have a group that was never exposed to incentives. And then we have a whole host of clinics that were exposed to different types of incentives as they had a child. Yeah.
Just a clarification.
Yeah.
Clarification question. Sorry. You say the removal of incentive, but for the families themselves, some of them may not have any removal of incentive. There was never an incentive to begin with because they're first-time parents in the 2020 post era, right? Gotcha.
Yeah, so that's exactly if I understand you correctly, that's exactly the variation I'm going to exploit.
Exactly.
Yeah, exactly. So the design, the key feature of the research design here is basically not using the experimental variation that I created, but using an additional element of variation that, people weren't timing their children according to weren't timing their children according to the incentives. So what you want to think about, you live in a community and some people had a child during 2016-18, this was their second or first or third or fourth child, and they would have been eligible for the incentive. But you had friends and peers in your community who may have just had a child before the incentive was introduced. So they did not have a child during the time when the incentive was given. And so they observed the incentives, but they weren't eligible for it, meaning they weren't directly experiencing it. And that we think of we have balance tests and everything, but they are, this is they're random. However, what I'm going to be doing is I'm going to be mostly drawing comparisons within these groups, and then I'm going to compare across. There are some small imbalances, meaning these people have number of children 3.6, and these people have number of children average of 3.1. That is a meaningful imbalance, even though it's 0.5. So the research design is going to use that natural variation that some people would have had a newborn during the time of the incentive program, meaning they were directly exposed to it. And some parents would have observed the incentives, lived in incentive communities, but were indirectly exposed. And I think to me, this is a nice design that I think there's one people now that are looking more at environmental stuff as to citation, but it's something we should really think about, I think, when thinking about incentive policies, because most of the time, we're not just trying to change behavior for environmental questions or whatnot for the current people. We're interested in all generations that follow. Even though I may not yet buy a car because I'm not yet 18, so the EV is not my question, but I'm going to soon be 18. So what are the spillover effects on these indirectly affected populations? So we're trying to get change in overlapping generations. So anyways, and there's another thing here though, as you've seen from the messiness of what's going on, and I think that's characteristic of many policy environments, we're going to think about the effect of the exposure to the incentives, so the implementation. But then also what might be a treatment effect, which in lab experiments you don't think about, which is the removal. Like everyone who had an incentive in some sense was exposed. Juliana, you were saying they weren't, but in some sense, even if I wasn't directly given the incentive, I would have seen it and all of a sudden it disappears. There's two things that might be going on as a treatment effect. So now let me show you how we're thinking. Yes.
So the original experiment was just measuring the effect of incentive on trigger.
Yeah.
And what did you find?
I'll get to this in a moment, rehashing it. The key result was that the one incentive that was working as a signal, which was tied to the last vaccine, which was perceived very important, increased take up by 13 percentage points. And the other two incentives had small positive, but not significantly detectable effects. So there were large positive effects. I'm going to get to this in a moment. So just give me a moment. I'm going to rehash the effects, but there were no negative effects. During the time of the implementation for the 2-year period, even slicing it by cohorts, not just looking at the aggregate, there were no negative effects. And I'm going to go into this a bit more in a moment. Yes.
I'm wondering, do you think the vaccination changed their infant mortality rate or their fertility rate?
I'm not able to pick that up. If you want to pick up mortality rates, you need much bigger samples. So I can't speak to this in my data. I have reported data because I'm always serving all children, regardless of whether they survived, have moved, or died in this context. but I am not powered to pick up changes. So I have a mortality rate of 4, 5, 6% in the sample.
Okay, so that's not the reason why they have such high fertility, like 4 or 5 children.
No, I can't pick up treatment effects, but they do have, for a host of reasons, very high fertility rates, and yes, there's also a high mortality rate among women and children. It used to be the country with the highest maternal and child mortality, no longer is, because other countries like Afghanistan and whatnot have, for that reason, taken over.
I'm just thinking about in families with multiple children, how rigid is the vaccination schedule? So could a child have the first shot at any point in time? And then are they spaced yearly regardless of?
Yeah, so
I mean, in other words, could you have incentives because you have someone who has a newborn at the time and then they decide, I've also got my 3-year-old who's pre-programmed, I'm going to get them vaccinated at the same visit or?
Yeah, I should probably add this. Thank you so much. I should add this slide more in this probably important context for someone. In this context, unlike to the US or other OECD high income countries, vaccination ends at the point now it's 15 months. Actually, with the malaria vaccine, it's going to be 24 months. But at the time when this was implemented, routine immunizations would have ended at 12 months. So it's not like in the US where you take your kid back for other vaccines later. And there is a specific timing. You have dates when you're meant to get certain vaccines. And that's why, you know, this intervention originally was very much focused as well on timely vaccination. So your child wouldn't be unprotected in an environment where there's a very high disease risk and could potentially get diphtheria or measles. But it wouldn't be that overlapping what you're describing. I just take my other child. You would be done, take a year, whatnot, or a year and a half, and the next child is born. Yeah. So,
So does your data set have in it multiple children in the family?
yeah, that's exactly what I need to exploit.
Sorry.
So what I'm going to be doing, no, not at all. This is with you, so I'm only presenting this in the new version first time, but this is the 4th time I'm presenting this year, so it's not like been like a million times out in a very short form. So just to be very clear, people who have had a child during the implementation of the incentive program, I observe their past child and I observe their next child. And then there are people who would have not had a child during the experiment, and what I'm going to observe is their next child only. And I'm going to mostly look in the analysis here at the future children. But I'm going to exploit this variation in whether they were actually exposed to the incentive or not. So let me describe this. I think I'm repeating myself here, but hopefully this sort of diagrammatically, or however you say this, helps you. So we're going to draw a comparison generally between people who were not exposed to an incentive, so they were in the control group, and individuals who were exposed to the incentives, any of the bracelet treatments. We're going to look at them separately, but for now, just think about no incentive versus incentive. Then most papers, what you would look at, they would say, okay, you were exposed to the incentive, which means you had a baby during the time when the incentive was implemented. And now what I can do is I can look at people who were never exposed to incentive versus those who were exposed to incentive and look at their next child. What we're doing additionally here in this paper is we're going to look at people who didn't have a baby during the intervention, lived either in the control groups or lived in the treatment groups. And the way we can think about sort of like 3 mechanisms that we have in mind that are really important. What could create differences in behavior on the future child between control and incentive groups? On the one hand, you might imagine that when the incentive gets taken away, everyone notices that no longer bracelets are given out. And people might infer from that, for example, vaccinations are no longer as important. They might just, and everyone could update according to those. So that's the removal of the incentives, and beliefs updating could, happen to both of these groups. Similarly, something I was really keen on and we collected a lot of data on is how the implementation of these incentives might actually impact community behaviors, community members or clinic staff's behavior in general, whether it means they do less reminders to parents, less outreach, sort of like compensating the effort away, or there's just some sort of greater enforcement at the community level, norms are sort of changing. Again, this is something that this community or clinic level impacts that we would expect both types of parents are exposed to. Whether you had a child or not during the experiment, you would be impacted by that for this future child if these changes had occurred. But the one thing that wouldn't have occurred is that only these people really had the individual level experience of being exposed to an incentive And those are sort of the three mechanisms that I had highlighted at the beginning that really the theory normally engages with, which is, sorry, this is very unsmart, but I just wanted to kind of go back to what I had said. I'm clearly not able right now. There should be a button. Oh, did I not have this? Sorry, here we go. These are sort of this one economic theory, sort of borrowed from sociology and psychology. These kind of mechanisms that are here at play would mostly come as a result of experience of an incentive. And that is really that component that we're trying to hone into when looking at, this comparison between those who were directly exposed to the incentive versus indirectly exposed. And this is obviously a little bit more messy. And just to be clear here, for example, hypothesis 3, like how what would have affected as a result of removal of the incentives versus, clinic or community level impact. I would predict that both of these groups are affected. So I need to pull in survey data and other heterogeneity analysis that we're going to do to kind of say, could it be this or that? But I'm not going to be able with this design to distinguish the green from the red, right? I can maybe say something about the blue because only those people were individual level experiencing the incentive. So what I'm going to first do now, I have about 35 minutes, I think. I'm first going to show you very simply what is the impact of direct or indirect incentive exposure on timely vaccination. So what we're going to do is we're going to run a very simple regression, where as a left-hand side variable, we're going to look at the total number of vaccines your child has received on time. And I'm also going to look at each vaccine separately in a moment. How that sort of timely vaccination effort is affected as a function of the exposure to the the level of treatment, the treatment you were exposed to, which is either control or one of the three bracelet incentives, but then interacted with the exposure indicator, meaning some people were indirectly exposed and some people were directly exposed to the incentive. So, and how do we think this? So timeliness, I think we're thinking about is sort of capturing effort. Like there's a lot of shocks in this environment. Someone is sick, you have work to do on the farm, various things. Being timely really requires a lot of effort that you go on the exact due date or like within a few months of that. But there's another measure, and I'm probably not have a button here, I'm not going to get to this, but if you ever came at 15 months, it's really like a reflection, I think, of your attitudes and your preferences for vaccine. And as I said, we don't find results here. These sort of differences, negative effects are picking up here, they're fading out over time. So eventually you will vaccinate your child. So the main outcome here we're looking at is the one that the incentives were trying to affect, which was, would you timely complete vaccines? That's what the signals were tied to, or the green bracelets. Any questions? I just saw, no, okay. So in terms of data, we're not relying on administrative data. We did in-person surveys with parents and children born in these original study communities. There was some attrition because some people moved or some people were traveling at the time for a longer time. Some children had also died at the time we were surveying them, but we're balanced in terms of attrition. It's fine. Not talking a bit more about this in the paper, but I think it's nothing to worry about. In terms of the vaccination data, we're relying on caregivers, like parents have like a card where the vaccinations are written down, but we're also asking them for memory. But 95% of people actually have a growth card, so we can directly record it from that. And then this exposure, how do we verify that? As part of the survey, we captured how long parents have lived in these communities and also recheck whether they had a child born during that time. We're also doing merging, but very messy because every child, not every child, but there's a lot of similarity in names. And so merging is a bit more difficult with the original data. So we also try to the best possible create this indicator.
I just have a question about exposure. So,
yeah.
There was that period after the experiment ended when the nurses were still kind of handing out the
Yeah.
bracelets. Are you counting that as direct exposure to the experiment, or?
So I actually couldn't. It's a really good question. So I'm dropping it and reminding everyone it's this period right here, right? It's kind of messy. So there are two issues with it. Not only is it the case that it's difficult for me to think about. So we have results on this one. And in this period, we don't immediately see negative effects, which I think is kind of maybe to be expected. The treatment effects on the experiment are slowly going down. And then as we're entering the area here, are negative. And we're checking, sensitivity to the cutoff in the sample. But also, as you might be able to imagine, not having a lot of kids here who were directly exposed. Because I need to give you some time to have another child. So I can actually only look at that in the real long run, because what I need is there will always be people who didn't have a baby here, who might have a baby immediately here, but those who had a kid here, I need to give them some time to have another one. So this is the sample where we're really having comparability of these two different groups in terms of age, caregiver characteristics, and so on. Yes.
And just to clarify, did you sample the same people who were in the previous study? Like you're going back and visiting those exact same people, or it's you're drawing a new sample?
So what we're doing is we're going back to exactly all the same communities that were part of the original experiment, so are part of these clinics. And we're surveying everyone who's living in these communities.
Okay, so it's a census.
So it's a census. And then we're basically verifying, though, were you living in these communities during the time when this experiment was implemented? And were you having a child during that time? Which we also know from merging part, I mean, but we do that. And so partly we're having data, these are the directly exposed, on people who were part of the experiment in the sense of the experimental paper. Those who were, having a child during the time were eligible. But we're now also adding on all these people who would have not been part of the original incentive evaluation, who did not have a child at the time, because we're now looking at their vaccine decision-making for the next child for both groups.
And then are you like controlling the number of children?
Yeah,
Okay.
yeah, controlling for all of that.
Yeah.
And also going to do conditional average treatment effect analysis, so causal force analysis in the moment, where we're looking at heterogeneity exactly on these things. So now going back to just show you, I guess I have to speed up a little bit. So here I'm just showing you what the incentives effects were during the implementation. And I'm just looking at the one outcome, which is looking at the total number of timely vaccination. So this is the setting. There's 5 vaccines to remind you. We already at a pretty high level. When you're thinking about there are a lot of always takers. So meaning like the average, the control mean is at 4.3. So really the reason why we're getting drop off is there's basically only 60% or so of parents get the 5th vaccine, on time. We're basically getting a drop off towards the last 2 vaccines. And so we're seeing increases in the reward that was working during the time of the implementation of about 0.3 vaccines. And then as with us, like we're seeing in the other 2 incentive treatments, we're seeing positive effects that are much smaller, but no suggestive evidence at the time of the implementation that there were negative effects. And I think I may not be able to get to this just to let you know, we are looking at heterogeneity in here. So we're looking at subgroup analysis as well here, basically looking at people who had more children at the time, people who lived further away from the clinics, mothers with less education, more education, people who are in smaller communities, the covariates we have. And we don't pick up any heterogeneity in these treatment effects during the implementation. So we have no suggestive evidence that the treatment effects you're observing while the incentives were implemented were masked by some already positive or negative effects, that some people already negatively responded during the time of the implementation. Okay. So now I'm showing you here the effects for the same outcome, which is the treatment effect on the total number of timely vaccinations post, incentives disappearing. And again, for the 3 different types of bracelet treatments, so it's compared to the control group and split by what the effects are that we're observing among parents that were directly exposed to the incentive and those who were indirectly exposed to the incentive. So first of all, I think when you just look at that image, what you take away is there's clearly negative effects. That's what's standing out. And there's negative effects across. So then we can kind of say, okay, well, clearly significant negative effects in the double reward. Remember, there were 2 bracelets here, and in the initiation reward among the directly exposed parents, very clearly. But much less so, and significantly different, as you can see in the p-values here, for the indirectly exposed. So this is the p-values looking at the treatment effects for directly versus indirectly exposed parents. Yes.
So in the green bar,
Yeah.
you have direct exposure. There you're comparing
Control group.
people in communities that never receive the bracelet.
Yes.
People in communities that receive the bracelet.
Yes.
But they themselves may or may not have received the bracelet.
No, so yeah, exactly. So the directly exposed received the bracelet.
Oh, they did.
Yeah, so they were eligible for it, and the implementation fidelity was so high during the implementation that we were like over 90% of people received a bracelet. So everyone received a bracelet. So the directly exposed, I'm just saying directly exposed because of the eligibility, right? They were eligible for the incentive, they had a child and they got the incentive. And these are the people who would not have had a child during the incentive program, but I'm looking here at their vaccination behavior for their future child. And I'm comparing it to the control group, their relevant control group in those two groups.
So the control group is the same for the
Uh,
directly exposed.
wait, hold on, now I'm fitting, no, because there is similarly in the control group people who had a child. That's why the important thing is not the incentive. I need you to think about eligibility in terms of did you have a child during the incentive program? And that could have been a child in the control group or a child in the incentive group. And indirectly exposed means you just didn't have a child when this experiment happened, and you could have been in the control or in the incentive group. So what I'm comparing here is people who are in the control group, did not have a child during 2016 to 2018, to parents who did not have a child during 2016 or 18, but resided in communities where incentives were floating around. Thank you for helping me. I know I'm not succeeding at it. Yes.
I know you said there wasn't any kind of heterogeneous treatment effects in the first study, but I guess.
They will be here.
Okay, because
I'm gonna
the
get
direct
to this.
exposure, I guess they're necessarily younger than the individuals in the direct exposure because they haven't yet had a child.
No, there is a small difference, as I said, in terms of number of children. This is nothing, so it's not driven by first time births. It's 3.1 and 3.6 children. The average,
Okay.
half a child less. There is a little bit of a difference. The point is you had a child and it's not driven by first time.
Okay, so no difference in having had a first child.
No.
They all have it, or
Maybe
similar.
I don't want to say this right now. I don't
Okay,
remember
yeah,
the
yeah.
balance table, but that's why what we're doing is we're comparing like with like,
Yeah.
just going back to this question, and then I can compare the difference in treatment effects. Okay. So I think so. Main takeaways. I think you all have something to do in 25 minutes, so I do have to hurry up a little bit. But like we find negative effects among parents who were directly exposed to the incentive in all of the treatments. Incentives without a signaling value. I mean, where people valued having the screen bracelet, reduced timely vaccination by 5 to 11%, and we find smaller and insignificant effects among parents who were originally exposed to an incentive that was valued to show that they were a caring parent. And among the indirectly exposed parents, we find, they're mostly unaffected by the blue bars you see in terms of negative effects. So now what we're doing next is kind of saying, okay, how do these treatment effects really link to, yes.
So the people who are directly affected. I'm trying to think about, you're saying it's intrinsic or extrinsic motivation, but should I think about the bracelet as like a reminder?
Yeah, so in the original study, that was one of the plausible explanations by just giving out these bracelets that all of a sudden people are reminded because there's something visual that is about vaccination. And so that's why there was this bracelet group, which was called back then uninformative bracelet, where you would only have been given a bracelet at the first vaccination. And then you had bracelets floating around. It could have been yellow or green, but it wasn't really carrying any information. It was like sort of a reminder. You could have imagined reminders were happening here too. What I'm trying to say to you is this was a major concern, or like a big concern, potentially what could have happened that influenced behavior in the original study. And the evidence suggests that reminders were not what was driving the large positive effects we're observing in the treatment here, which was the signaling reward. Not these coefficients right now, because this is post. But to your second point though, and this is something I won't have time to discuss today, I thought, but I'm going to address it now. In the paper, there is a question, which is, if I introduce an incentive that is not just a payment in this instance, I'm swaying you to do vaccination, but as you rightly say, it's actually an incentive that could serve as a reminder, right? It has a purpose, like it helps me to do something where I otherwise need to exert effort. It could have led me to practice less reminding myself, because now I have all these bracelets floating around. And once you remove the bracelets and I have the next child, I'm basically no longer in the habit of reminding myself. Okay, good point. So what we do have in the paper is questions on, were you reminded? Did you talk to others about vaccination? And we find no significant differences across the control and the incentive groups when it comes to that. Yes.
They have greater sense of urgency. So the direct exposure group, they had children, it was more salient for them. There was a campaign for using bracelets. You must be really important with vaccinating methods now. And then when this was removed, was not the measles.
Yeah, I'm going to get to that. Exactly. These are all the mechanisms we have to wrangle with. Right now, what I'm trying to do is basically just show you these negative effects that we're observing here. I'm trying to show you that this is sort of linked to the incentive pattern. So what I was trying to show here, and then I'm going to try to get to the different hypotheses in a moment of what's happening. So what we see when we're kind of unfolding this number of timely vaccination, which I just showed you, these negative effects you saw on the graph, and we're actually looking by the 5 separate vaccines, what we observe is that the negative effects in behavior line up really well, or like line up with how the bracelets were given out in the 2 rewards where we see negative effects. Meaning, generally speaking, we see negative coefficients on the first bracelet where they would have gotten that reward. Significantly so for this double reward and initiation reward. We see some spillover, onto the second vaccine. To expect it, you were kind of late for the first, some people miss the second. And for the double reward, where we have another incentive here, we see large negative effects here too, spilling over again in the 5th. The important part here is when looking at the reward that had a large positive effect on these later vaccines, we observe no negative effects here where the incentive was placed, which is different from what we're observing in these 2 other rewards. I think I have to just speed up if this is not all clear, so I get through the rest. But we argue that these negative effects map onto the original incentive schedule. The initiation reward has significant negative effects only on earlier vaccines. Double reward we see throughout the schedule of 10 to 20%. Ditch points declines, and we find no negative effects for the incentive that was allowing parents to signal that they're caring. So now I'm going to go back to one of the 3 hypotheses, which was just the question, where could this all just be driven by changes in how the nurses maybe exert effort, or how there are community norms around vaccinations. So the first explanation, I think, as you can already tell, given that we're finding significant differences between the exposed and indirectly exposed, even though they're living in the same communities, they're interacting with the same health workers, this doesn't seem plausible. And to be clear here, there's like 80 caregivers in the clinic, there is no electronic records. It's not like a nurse can directly tell who got vaccinated. I mean, who had a baby before or after, and everyone has babies, just sort of at different times. And however, not just relying on this design, but also we collected a lot of data on actual supply side effort, or community norms, bylaws, fees, fines, whatever the village chief does, and we find no significant differences across control and incentive groups. The second question you might have, as you can see in this interim period, where bracelets are only given out to some people, that clinic staff might be discriminating who to give a bracelet to and not, and that kind might actually lead to disappointment or disincentivizing people to show up if they learn that only some people get it. Again, we have survey data here and we can directly check. And we find that the directly and indirectly exposed parents are equally likely to receive a bracelet. So it's not like that nurses were differentially now giving out bracelets, and this could have affected the motivation of people to show up. So we find no evidence overall through survey or the vaccine data that this should be driven by changes at the community level or the clinic level. So now, before digging more into these mechanisms, I want to talk about differential effects across the groups, so heterogeneous treatment effects, which came up a bunch of times, and partly because I am going to use that to talk to the mechanisms, the remaining 2 in the end. I'm going to use the effects from the heterogeneity analysis, but I also think there are 2 first-order questions here, which is the null effects that we're observing, for example, in the reward that did work, and didn't subsequently have negative effects, or the indirectly exposed. Are these null effects maybe masked by positive and negative treatment effects? And the second important question is, what groups are most at risk of negative outcomes? So, what is it? We have individual and community level characteristics, and we can learn more about who are the people who are most affected, by potentially less vaccinating their kid. And this is, I think, very relevant for policy efforts and to kind of mitigate these effects potentially. So what we're doing is we're using, sort of new methods that have been developed by Susan Athey, sort of a causal forest algorithm where very simply what it does, it essentially splits the sample that we're observing of caregivers into different subsamples and does that in a very efficient way in order to be able to pick up heterogeneity in treatment effects. And it does that by using as well the characteristics that we can feed it on an individual level and community and clinic level to kind of create subgroups across different quantiles. So the key thing here is, or what I want to say is we're giving it a bunch of characteristics and we really don't have this much available, but I think we have some meaningful ones that you already mentioned. So we have a set of characteristics that's related to the cost of vaccination, which is the number of children or the number of parents that surround you. People often go as a social activity together to the clinic or remind each other. So it might actually matter how many other parents you have around you in order for you to make effort. Then also distance, this should probably be the first one. One of the highest predictors in the original paper is distance of walking. They walk between 0 and 5 miles. The average distance is 1.8 miles. And how many kids you have at home. It's like a large opportunity cost whether you actually go with your newborn to the clinic. Then the second part that really might matter is your understanding of the benefits of vaccination. What we can look at here is the education level of mothers. And again, what might matter here is your birth order, how many children you have in terms of experience with vaccination, and how certain or uncertain you are about the benefits and cost of vaccines, as well as your age. And then we have another set of variables, which is talking more about how interactions are working with the nurses. And so while I told you something about discrimination already, I think this is not fully resolved with the argument I gave you. So I collected some data based on lots of work I've done there. What stood out is that how mothers might be differently treated depending on how well dressed they are. So they have a special way of dressing when they actually go to the clinic. And this is obviously influenced by how poor they are or how wealthy, quote unquote. As well as if you have really large clinic populations, there is more sort of anonymous relationships with this, like much smaller clinics where nurses are very familiar with what mothers are coming. And so to what extent the nurse is kind of scolding you or preferentially treating you might be relevant here. So other variables that we explored was also ethnicity, first child, as you said, and above median children. We played around with different definitions and that doesn't matter. And at the end, we just went for birth order, just put in the entire continuous variable. So what we find by implementing this CATES analysis, conditional average treatment effects, we find, as I just said before, very clearly, importantly, we revisit the experimental data and we find no significant heterogeneity. I'm going to give you a quick look of what this looks like normally. So the way this looks like, the results of this conditional average treatment effect analysis is that we have been splitting it, we've been telling it to split it in 3 terciles, where it kind of like uses the data on the covariates and tries to explore heterogeneity and treatment effects. And on the y-axis here, it always shows you the treatment effects on total number of timely vaccines. And this is an image where it tries to do that for the initiation reward during the time of the experiment. And you can see it's really not able to pick up any significant differences or like heterogeneity across subgroups it's dividing. And it similarly doesn't really do for the double reward, and it doesn't really do that either for the signal at 5. Now, a very different image is about to emerge when I show you how we're getting sort of monotonicity and significant differences across terciles, like this being the first tercile, here the third tercile, and we're observing significant differences in the treatment effects compared to the control of the initiation reward on the total number of timely vaccines. So this difference is significant. Just want to show you this graphically so you have something in mind of what this looks like. Similarly, we observe differences for the double reward, and we observe nothing again for the signal. And so overall, we basically observe significant heterogeneity even in those treatments along the direct exposure. And the variables that are really predictive here to kind of learn about who's most effective, it seems like the distance to the clinic, so kind of cost of vaccination is really predictive in terms of who is most negatively affected. So we find that there's a large difference of about 1 mile walking between people in the first tercile and in the third tercile. And similarly, what seems to really matter is the number of caregivers that are surrounding you. So other children that are of similar age where we find differences between the first and the third tercile of, 18 parents versus 47 parents, or 14 versus 34. So quite, tripling in size of the population of other kids and caregivers around you. So we find also some heterogeneity. I think I'm running out of time here a little bit, but let me just tell you for the indirectly exposed, we also find heterogeneity that is rather uncorrelated with characteristics than what we're observing in the directly exposed. So distance, for example, is not predictive there, but small clinic population correlates strongly. And interestingly here, for the indirectly exposed, which was very surprising, we're picking up even positive effects at times. So we're picking up negative effects, but we're also picking up actually negative effects, but also positive effects for the indirectly exposed. The indirectly exposed basically is a lot more noisy or heterogeneous, and also gives us different covariates. And I'm going to tell you what we sort of make of that, but this is what we're learning from the heterogeneity analysis. So the three takeaways we have here is that there's significant heterogeneity in treatment effects among parents directly exposed to the double initiation reward, where we saw the largest negative effects. And the strongest negative effects we find for subgroups that have higher vaccination rates. We find no evidence of heterogeneity among those who were directly exposed to the signal reward, which suggests that there's no negative effect among always takers that could have actually been hidden. I think one of the big concerns is, well, maybe the people who you moved to take the action during the experiment, they formed a habit, and you actually similarly have negative effects among the always takers, but we just don't find any evidence given how predictive otherwise our covariate analysis is. And then thirdly, we have evidence of both positive and negative effects among the indirectly exposed, which really suggests here that there is a shift in who vaccinates on time compared to the control group. And covariates that are linked to negative effects differ by exposure groups. So we think that there are different mechanisms at play for the indirectly and directly exposed. So now the question really is, so I've given you a lot more information, sort of what we're extracting from the data with different analysis, and what you're probably left with is, well, what explains now this lower effort of timely vaccination? So let me revisit sort of the two groups of explanations that we think are most relevant in the setting. The first one is you had an experience of an incentive, and that might have actually led you to lower your intrinsic motivation. Why is that? On the one hand, there's, theory that's saying, well, this is kind of behavior you don't take every day, you take that every few years. It's a very high cost. And you might just be like, well, why did I walk 4 miles the last time, and so on? Do I really have to come directly today? And we're not talking about ever coming, right? Do I really have to make the effort to come timely? And you misattribute this, or you just have built some future expectations to implement it for 2 years, and you kind of like, well, I really think about the reward that should be given to me, and it sort of like lowers your intrinsic motivation. The second class of explanations is like, well, this has nothing to do with you being exposed to an incentive, but the removal is really what influenced people, and they potentially, by taking away an incentive that was given for 2 years, people sort of learned or updated their beliefs about the benefits of vaccination. Now, let me go, this is the last part, through each of these explanations and how we're sort of putting the data together and what we think is most maybe plausible as a mechanism ongoing. So when thinking about the self-perception and imperfect memory, right, like parents remember vaccinate, what you need for that is, for the story to have any bite, is that parents need to remember, first of all, that how they vaccinate their child. And they secondly need to clearly remember that they received an incentive, for this to even be a plausible story that you could misattribute why you took the action. And then thirdly, obviously, that they imperfectly remember their intrinsic interest and why they took the action. So the last part I don't have data on, but I can speak to the first two parts. And in this follow-up study, we did implement survey questions, and we basically asked, obviously, people if they recall, not only from their growth card, but whether they recall the last vaccine of their child. And even after 2 to 3 years, 83% of parents recall the last vaccine of their previous child. And 94% of those who were in the incentive groups report receiving a bracelet at immunization and remember the bracelets. So combining this with our Kate's analysis of these heterogeneous treatment effects, where we see that negative effects are strongest for parents that are facing higher cost of vaccination, a plausible story we think here is that when the action is more costly for you to take, you have to actually walk quite a few miles, that you might be more likely to deliberate a decision point on whether to go or not, and that you therefore might be more sensitive to misattributing your past action. And we think that this is a plausible explanation given the data that we have. The second one on future expectations, that you begin to expect a reward when it's consistently implemented and you rely on extrinsic motivation. So you have to think about the environment we're talking about here is one where there is no established norm for receiving anything at a clinic in terms of a reward. So really, we implemented this on the back of like people don't receive gifts. They don't receive nurses, things from the nurse. They may not even reliably receive what they ought to be receiving, which is a bed net or medicine. The only thing that sometimes is given to caregivers is food for malnourished children. But even here, only 20% of caregivers report to receive it, and there's many more that should be given it. So basically, this program of an incentive really introduced a valuable gift that was clearly tied to immunization and was very reliably given out for 2 years. And so given the short run effects that we observe, this is different. It was valued. Just believe me, it was valued. We have data on this. So what we see that the health workers in the interim period are continuously implementing the incentive despite complaining, and we have more data on that from the experiment that I never thought I would need. But how much they were reluctant to exert extra effort, and rightly so in 2 arms, because it didn't do anything, provides, we think, actually suggestive evidence that caregivers were putting pressure on them and wanted to have these incentives because they kept doing it for another 2 years, when really it's a high effort margin for them. Yes.
Can you go back to why you think it's a valuable idea?
Oh, yes, I can show you this. So the real question here is, which normally we can't really pick up, is, so just bear with me for a moment and I go to the table. The main incentive where we sort of, that is implemented across the double reward and initiation reward is really, when they get a bracelet the first time, right? And the question is, do they value that bracelet? Now there we are at a level of 99 or 98% take up. So actually I have a ceiling effect. I can't actually pick up the value normally in aggregate. But what I can do is take up decreases with distance, right? If I go to further communities, it's no longer 98% who are taking it up. It is much fewer. And I can kind of look at what do the effects of these bracelets do on the first vaccinations in those 2 arms. And I see that here, as I said to you, I'm really high, but as I'm going out further out to communities where take up is lower than, in these close communities where we're here at 98%, at 100% and so on. If I go to far communities, I don't have the levels here, but it's much lower. It's like more in the lower 90s and the 80s and so on. I pick up positive effects throughout at the beginning, which suggests they did value the incentive. They did value receiving the reward. Do you know, the only way that I can pick it up is through immunization behavior.
So they knew they would, if they went and did the vaccination, they would get the bracelet.
Yes, so again, maybe need to give you more detail, very much so. We did a lot of information stuff. This was implemented over 2 years. You see this consistently with cohorts. They have knowledge of that. They knew in example that was really important that when they go to the clinic, they would receive that first bracelet. Not only learn about what subsequently happened, but they knew that they would be given this incentive. I just haven't, in theory, I can't really convince you of that in the aggregate data because a lot of caregivers live close by and I'm reaching a ceiling effect to pick up these positive effects. But if I limit my subsample to further away communities, I am more able to pick up the positive effects that giving out an incentive had, even just a first bracelet, a pure incentive, which had nothing to do with signaling. A little bit, but not that thing. So this is where I'm saying there's a positive effect of the incentive. Let me go back to the other 2 parts and wrap up since I only have a couple more minutes. So, so we think that overall, given the data we have, and we're clearly limited here in hindsight, you would maybe want to have a different experimental design to kind of get at these 2 mechanisms, and you could think of other data you may want to collect, beliefs maybe, but sort of the data that we can sort of stitch together on these expectations hypothesis, as well as potentially how people could have misattributed their effort. We think that these are 2 plausible explanations, this mechanism. When thinking about the removal, which is a very competing explanation, I think that had nothing to do with experiencing the incentives, but it's because you took it away, that parents might actually infer that the vaccinations are not as important. The first thing I can say here is that there's no evidence of learning in response to incentives. So we actually see that people, in response to the implementation of the incentives, people weren't really updating even after 2 years and changing their mind about the social benefits or the private benefits. suggesting that beliefs are not sensitive. And then secondly, it is also the case that the indirectly exposed and the directly exposed were similarly exposed to the removal of the incentive, and the indirectly exposed knew about the bracelets. 70 or 80% of the indirectly exposed had heard about the bracelet. More than 40% knew the bracelets were for vaccination, so it's slightly lower than people in the directly exposed, but still at high levels. And we see no negative effects in aggregate there. And then lastly, of course, well, if you think the removal story is the one that has bite, then we would have expected as well effects in the signaling reward, because there the incentive was as well removed. And there was a lot of responsiveness, like you could have had a high elasticity response to the Swift vaccine, as we have seen during the implementation. It's not like one where people's belief was unmovable. So we think that is not as plausible. And then the last one, I have one more minute, maybe, because we started 3 minutes late. So there is another thing in this, as you can see, I think these slides could have add on when we presented at Berkeley before, and the second crowd for a lot of you. So one more explanation could be as well, of course, that, the indirect, people just formed incorrect beliefs. They just saw the removal and they were basically incorrectly interpreting the phase out of the bracelet, sort of in 2 ways they could have. Well, they saw that fewer bracelets were handed out post-experiment, as you saw sort of that decline. And they could have thought, that means fewer people are actually going for vaccination. Or they could have seen fewer bracelets are going out and they thought, now, wow, this is so good. Maybe this is even more valuable. So here, I think this is for the indirectly exposed mostly, I would say, the case analysis, the heterogeneous treatment effects, we do see both positive and negative effects. So in some sense, you could say, well, this is actually sort of a cautionary tale. People who were not directly even exposed to an incentive program, the removal could do harm or potentially, create positive effects if they think they can still get it to these 2 groups. So this is something, we think could be going on. I think what's missing right now in the discussion that I give you sort of like everything we can fully roll out. I think I've been mostly presenting you things that we have supporting evidence. Completion by 15 months, I said before, we see no more negative effects. They kind of wash out, as you can tell from the coefficients and from the stars that I had indicated, still some remain. But for the signaling reward, we're even seeing positive effects, but nothing, significant that goes out. So the conclusion of the studies, I think this is one of the first studies. I know this is something you shouldn't say, but we checked, and we please want to hear from you if I'm missing something, to find evidence of crowd out persisting up to 2 and 3 years post-incentive in a real world and high policy relevant setting. Crowding out is mostly limited to those that are directly exposed. Simply hearing or witnessing the incentive, on an aggregate at least, does not have, impact motivation. Crowd out might be hidden. I think that's an important thing to take away, even if there are no discernible effects during the implementation, including, from the heterogeneity analysis that we did, there might be negative long-run effects. And it's suggestive evidence that, incentives as well that focus, however, on intrinsic motivation that are directly tied to that can potentially mitigate what otherwise might happen in an environment where there's, already a very high take-up and a lot of people would have taken the action in the absence of incentives. This is really important. GiveWell has already latched onto it. It's on their website. This is motivating a lot more further research. I think this is generally something that people have been concerned about for a long time, and there's discussion of doing this in a number of other studies. Again, very interested in hearing on ideas or having PhD students go out there. I think there's a lot of scope to learning about long-run effects of incentives. So thank you so much. If anyone wants to talk to me, I think I have time. So, but you don't have to. I mean, just a much.
Yeah, I've got a quick question.
Yeah.
Sorry if I missed it, Maria. Do caregivers travel together to these clinics?
Yeah, thank you.
Do you think that?
I got it from issues with a few other things. We have a higher possibility. So that's why we characterize or classify, because this data on like how many other might be more pressure.
That makes sense. Okay, great. Do you feel like this is like, do you imagine that this effect would change with like families that are close to them in far. It's like a travel idea. Oh,
So that's what we have, we don't have it here.
got it. Yeah.
I think we're maybe a little, underpowered or throwing that into but, generally speaking, I mean, the core is to do with the community analysis, like creating just creating a joint distribution of all trade, meaning like, it's just the case that people who are more negatively impacted are on average in smaller communities and bigger. So sometimes they move together. They're associated in the same way.
Okay, cool. I'm trying to figure out if it's like more of a story of like, I live in a small community with two of the caregivers, either like, I don't face the social costs of not like keep vaccinating my children, or I don't have other people to travel with me. I want to do it, but I face higher costs because maybe I'm a caregiver in Sierra Leone is.
Like, so I think it's just like concept, they're a little bit everywhere, like already on that whole that is
Yeah.
The basic obviously we will increase that, but there is, there's awareness of thought, so sometimes we like in smaller so we don't try to keep that up. It's just like on the argument of traffic. But in truth.
There's agreement.
Like a talk, I like to say it 2 by 2. Directed interaction. That's great. For understanding what you're doing. Keep that.
Yeah, no, that was always there.
Good, good.
Maybe we should do that earlier.
Yeah.
Are you asking?
Yeah, I'm listening. No.
Okay.
I just had a question about the bracelets. Do you have a way to enforce wearing them? 'Cause I mean, I saw they were adjustable clearly.
That they are, that they are,
Okay.
so they're not meant to be different, from, and that's why it reveals the by signaling. And the original study that people could wear them, what we don't observe in the long run is that they recycle these, so it's not like they're lying. I mean,
Yeah, they're not
they
doing
had a
that.
child and they give it to.
I was gonna ask
No,
about
we
that.
don't have this on the slides today, but
Uh-huh.
we have no evidence of this.
Okay, and then how did you observe whether or not they were? I mean, I guess you observed.
We went on, we went in, survey, and we were just on the spot observing whether they were wearing it.
Okay, cool. Were a lot of people still wearing them?
This is the original, oh, no, and the follow-up, no.
In the follow-up, no,
No,
sure.
the follow-up, no.
'Cause everyone's
But-
already
And the kids are
old.
big, no, but
They
in
kept
the
it.
original study, yes.
Okay,
And there was a gradient, they were less likely to wear it over time, and people were worried about losing them, which subsequently made us change the design for the scaler.
yeah,
But the important thing is that you want to elicit beliefs of others or knowledge of others, whether you have a bracelet or not.
yeah,
And they were like, 80-90% of people knew whether you had a bracelet or not, and the color of your child correctly.
yeah.
So there's very high knowledge in the community and awareness and salience of these bracelets
Yeah.
in the original study.
I see, I see.
When it was implemented.
Yeah, cool.
So what's happening now?
I don't know.
I meant to sit down and then,
Martha walked up and she was the faculty here, but I don't know. Everyone's gone now.
oh no, I thought I meant to. Meet but I
Oh,
didn't
that's not
say,
me.
Right?
That's
Oh,
not me. No, you're meeting with someone else. Do you know their names?
I can take a break then.
If they're in this room, I can point them out.
Andrew Hess,
Not here.
David Henning.
David Henning was here. Maybe I didn't see him.
One.
He's not here.
And then Victoria.
Or, yeah, I think he's right there.
Okay, cool.
Then
Maybe
actually-
that means I can just take a break
Or-
and kind of write down the questions in my
Actually,
book.
maybe that's not. I'm not 100%. Yeah.
Do you guys play table tennis in here?
I think we're gonna have a tournament later. I don't know if that's been used
That would have been
recently.
very interesting. Yeah, good point on the recycling.
Yeah.
It's a question that Oriana, Madeira, and you and I came up with that very immediately as well. So,
Yeah, just imagine. My first colleague was out of it. I just use them.
Yeah. I just want to double click, because I think my pig got soggy.
Oh, yeah. Grace, do you need help cleaning up or anything? I'm just gonna that.
Oh, I'm gonna try to.
Oh, you're good, okay, cool.
I.
Hey, you got to me when you're working at research.
Wait, listen to me here. I was doing the time.
like.
What time is it? What time are we meeting?
At 1:30.
Oh, 1:30. Okay, well then I'm just gonna sit down here. I'm gonna have some.
You know, I
fun.
just remember that.
If you want.
Where's how many?
Talk to me about your research. Introduce yourself. I can try to help you with your research. You can talk about mine, but I prefer talking about yours, given you're a PhD student. But it's not.
There's definitely like, I don't, not in the.
You are fine, you know? Maybe one second. Oh, no, we're. Then.
Yeah.
I mean,
I know, I was like, there's no.
Oh,
Mm.
Okay, cool.
I did.
Well, yeah, and also I hadn't,
Seriously, it's a follow-up paper, so a lot of.
yeah, there's a lot
Hard
of,
to know.
yeah.
I'll follow up.
Oh my God, yeah, that was a ton of money that I threw out.
Oh.
I love it.
David will come, he's a development economist. Cool. David, so he's one of the PhD students. What was it? The one in London?
Yeah.
No idea.
Oh, okay, I was just wondering, is it, yeah, I was like, who is this? And so it's not faculty here.
They might be, but they even have economics. I've always been there, but. So,
Okay, what did you do?
so I'm like public and environmental, so
Cool.
I'm studying how people adapt to climate shocks.
Mhm.
So like how people are moving in response to California wildfires.
Oh, wow, that's super important.
Yeah, very, very timely.
Like actually moving, like change, like moving houses.
Yes, so I have like two sets of migration data. One is like credit data, so I can see exactly the census block people are at. And the other is like address level data, so I can see their exact address. So
Can you also see house listings and sales?
So that's not something I look at in my paper, because I'm mostly focused on just like, are they moving or not? But that's definitely like.
So I just said, I mean,
look at.
there's so much happening now, right? Like, I mean, Zillow next year is gonna introduce a new score, right?
I know, I saw.
Yeah,
the
it's crazy, but I
20
mean, I guess I'm just always curious because I guess it's sort of where you look at, but you just see whether it doesn't really matter whether they sell that house or not.
Yeah, so I think my reason for looking at their migration is that I knew there's like the dynamic social equilibrium models, trying to understand the welfare losses from climate change. They consistently find when you like shut down migration, that's when we see the largest welfare losses. And so like theoretically, it's a good idea.
Yeah, the always say migration is goodbye for them.
But
How long have you seen that there could be like transitory, I mean, there could be transitional periods, I mean, I don't know. Do most people move within, why don't you give me your pitch?
Oh.
No, are you-
The rest of the chair.
I will ask you opportunities.
Bringing the chair over here.
It is job market season at all schools right now.
Yeah.
So,
By the way,
Yeah, I think
my
we
main
have-
results will be presenting next month. Thank you.
nice.
One
to
of
meet
them. Hi, nice to meet you.
So my name is Anne. You may have gotten that, I presented just now.
You're working with Zach. Zach was a coworker of mine at the Fed in grad school. Yeah. That's why I'm mentioning this to you. Because I saw his name. I was like, whoa, wait a minute. I didn't realize that. Yeah, he's a buddy of mine.
Second PhD student in Chicago.
I
The nice
know.
thing about coming to Chicago is that, I started working with PhD students, which is really cool, either because they have an interest in development or whatnot, and yeah. I think Zach is in his, wait, Zach is now in his
Probably
fourth year.
fourth, third or fourth by
Fourth
now,
year.
yeah.
So this is coming to an end, so he's been accompanying them for the last year because, he obviously needs to go, or is in the field and doing his own stuff, but yeah. Been very great to have, help.
Zach was one of my favorite interns when he was at the Fed. Great dude. Yeah, love that guy.
So what's your name?
My name is Paul.
Oh.
I think we're all on market.
We are all on the market this year.
David, and, are you all the econ market?
Well, among other things, public policy, public health.
No, I mean, there's something wrong with the marketing market or,
But we're
or
all
is that, no, is that it? Okay, so how should we use our time? How much do we have?
now.
Or.
We have an hour?
Or I'm not.
No, I just wanna make sure because I think what could be useful,
Anyone have the
We have
sheet
till 2:30,
easily
we
accessible
haven't-
right now?
we have an hour.
Yeah.
Okay,
Do we? All right,
so what
great,
you could do is you could give me your pitches if you want,
sure.
and then I can give you feedback. Or you can ask me questions. It's probably not useful for you right now to think about your research design because you have a paper. I can poke holes into it, but,
It'd be easier for us to figure out how to punt or obfuscate or deflect or
no,
something.
you shouldn't do that. I think. the most-
Really? I shouldn't do that?
No, the most important thing you have to do, which I was taught by one of my advisors, I was at Berkeley, a grad student, and one of the most useful things I was told is because nothing is perfect, everything is messy. And actually the paper I went with on the market, my development advisor was very opposed to me going on the market with that paper because he thought it was just messy, and I had another paper. And
It's the same one, first stage of this one.
the first stage of this one was my job market paper, but I had another paper that was cleaner, quote unquote, I mean, a different paper. So, but the point is that you just need to demonstrate that you thought about it, right? Like you can't resolve everything with almost like when I tattoo it on your arm, I thought about this. It's just like, no, but it's really, really important, right? Like, because you can't, nothing is watertight, you know what I mean? Nothing is perfect. Most things are messy. Most things have some element of complication. You want to explain it as simply as possible, but you thought about it, and then you're gonna give a 3-part or 2-part answer, right? And not chew, someone's ear off or completely all over the place. But that will take you practice. It'll probably take you at least till January, so you have a ton of time. So do you want to get started telling me about your papers? This is the fun part of my job. You got started, so why don't you give me you may not have a pitch yet. It's just October. Aren't you guys all writing your papers?
Something like that, yeah.
I hadn't even written mine at that point. It was just started.
Seriously?
I
Okay,
wrote my paper. Okay.
that's awesome.
But that was it was a combination of, I had my intro on the 1st of November, the placement meeting.
Pile all the stress onto less than 2 weeks.
Well, I
It
think
sounds
there
so
was
much
very
better than
easy
what I've been
services.
doing.
No,